Thank you so much, Professor Dr. Maggie. Thank you for inviting me to this very scientific meeting. It's my pleasure to be here with you, and I'm very happy with the collaboration between the chest clinic and the nutrition clinic in the sake of the patient health. Today I will going to talk about one of our cases that came to the nutritional clinic. Sarah, she's 4 years old, female, first child of consanguineous parent. She's presented with episode of crazy stool that are difficult to flush, associated with abdominal flushing and pain after meals. She was full term, normal delivery, no significant prenatal complications. However, the child had a history of meconial ileus in the neonatal period, which required surgery. Investigations were done and the diagnosis of cystic fibrosis was proved. She came to our nutritional clinic at the age of 2 years with stunting, short stature, and according to our growth charts, she's below the first percentile regarding the height and the weight. I will not going to talk about the cystic fibrosis and the cause because all of you heard this before. And this is the systems which is affected in case of cystic fibrosis, and the clinical picture from laboratory testing and additional testing. This is the sweat chloride that we heard before, and the genetic testing. Here I am going to discuss the nutritional problems and why the cases of cystic fibrosis are susceptible to these nutritional deficiencies. First, because of pancreatic insufficiency and reduced intestinal bile acid content lead to malabsorption, fat-soluble vitamin deficiency, recurrent infections and bronchiectasis, GERD, behavioral eating problems, and decreased intake of many nutrients. It's very important to assess the nutritional status of these patients regarding ultraviolet measurement in weight, in height, in our length, head circumference, and height, length, and BMI. Clinical assessment is very important. Biochemical assessment according to the case, and dietary assessment with 24 hours dietary record. What are the best strategies to optimize nutrition in CF cases? In children below 2 years, the weight for length percentile equal to a greater than 50th percentile is recommended by the CDC. And in children from the 2 years to 18 years old, the nutritional status may be assessed by BMI. And they recommend to be equal or greater than 50%. And this is very important. In case of female, it is 22 kilogram per square meter, and in case of male, it is 23 kilogram per square meter. Why it is very important to keep these parameters? It's very important because WHO found that we are keeping these parameters. There is a lower forced expiratory volume and a better lung functions. Aspirin and estrogen and DSF, they are all of them collect the nutrition management plan. And there's 3 main categories. First one, high energy nutrient-dense diet. Number 2, vitamin, mineral, and supplementation. And pancreatic enzyme replacement therapy, which is very important. High energy nutrient-dense diet. In the usual case, in our case, which is 4 years old, usually the calorie need is 1,000 calories per day. In case of moderate activity, 1,000 to 2,020 calories per day, and in case of activity, 1,020 to 1,400 calories per day. But in case of children, these calories must be increased to about 1.5 to 2 times the typical calories needed according to the same age and activity level. So it will be about 2,000 to 3,000 per day in case of our, in this case. These are the healthy high caloric foods. For example, eggs, chicken, banana, cheese, dark chocolate. According to what the family can give the child, any of these, it's very important to give the high calorie foods. Also, use of medium chain triglyceride containing food is very important because these NCTs absorb independently of the pancreatic function, making them useful for children with pancreatic insufficiency. And these are examples of these food. For example, milk, butter, yogurt, cheese, dark chocolate, nuts, and seeds. Healthy fats, it's a very important word. It includes unsaturated fats present in olive oil, avocados, and nuts, and also the omega-3 and omega-6. Omega-3 we can find find it in salmon, and omega-6 you can find it in vegetable oils. And it's very important to make a balance between omega-3 and omega-6 to prevent the pro-inflammatory effect of omega-6 fatty acids. This is the plate of our child, containing fruit and vegetables, bread, rice, potatoes, meat, fish, eggs, milk, and dairy foods. In our clinic, we provide our patients with this nutritional plan containing different meals for breakfast, for lunch, for dinner, and in between. And our aim is to provide a high-caloric, nutrient-dense food. For example, these also another foods, as we said, one of them is the potato with milk, egg, and cheese. This meal will provide our child with a nutrient food. Vitamins and mineral supplementations are very important. And Espen has told us that the fat-soluble vitamins are very important due to the pancreatic insufficiency. This is table shows us the requirement of our child. The 4 years she will need vitamin A, 1 capsule per week, vitamin D 8 drops per day, vitamin E 2 capsules per week, and vitamin K half an ampoule orally or tablet per week, zinc 3 milligrams per day, and calcium from 20 to 500 milligrams per day, depends on the age. Salt supplementation. We have to know that decreased salt leads to decreased appetite, nausea, vomiting, lethargy, suboptimal weight gain, and also contribute to thicker secretion in both the lungs and bowel. So when the level is below 30 millimole per liter, supplementation is very important. In case, and this table shows us the recommended daily sodium supplementation. Pancreatic enzyme replacement therapy is very important, and according to the age, these are the doses. In case of a child 1 to 4 years, 2,000 to 4,000 units lipase per gram daily fat, and we can increase the dose as needed to a maximum of 10,000 units lipase per kg per day. After implementing a comprehensive nutritional plan and enzyme therapy adjustment, there has been noticeable improvement in the child's weight and size. Growth parameters have shifted to just above the third percentile. Weight 12 kilogram, height 84 centimeters. However, the child now reports only pain after physical activities, particularly in the lower limbs. Laboratory test reveals serum calcium within normal, vitamin D is below normal. So, what additional recommendation to address exercise-induced bony pain? In this case, it's very important to supplement with vitamin D as a maintenance or as a treatment. It's very important to give her about 1,600 to 3,000 by international unit of vitamin D, and then reassess the calcium status. After reassessing, the calcium and vitamin D were normal, but doing at 8 years of age a routine DEXA scan, osteopenia was noticed. What might be the underlying cause of osteopenia? As we said, malabsorption of fat-soluble vitamins like vitamin D, vitamin K, calcium, and magnesium, chronic inflammation, steroid use, decreased physical activity, acidosis due to respiratory causes. All of them will impact the calcium metabolism. The National Care in Children with Cystic Fibrosis highlighted the very importance of vitamin K. Regular supplementation of vitamin K at dose of 0.3 to 1 milligram per day for infants is very important, and at older age and adults suggest 1 to 10 milligrams per day of vitamin K. And we have to take care that during using antibiotic therapy, we have to give a higher dose. Now we have an impact of highly effective modulator therapy in gastrointestinal system and featured people with cystic fibrosis. Many people are relating these now, and all of them recommend the use of CFR modulator therapies, and these are examples of these therapies. Please don't forget, there is a strong relationship between nutritional status and quality of life, lung function, and life expectancy. The treatment goal aims to prevent the cascade of wasting precipitated by negative energy balance, reduced dietary intake, steatorrhea, and reduced lung function. Early identification of nutritional risk is very important and necessary to intervene at the proper time for better diagnosis and outcome. And thank you so much.
Thank you very much, Dr. Dalia. I'd like to thank the Department of Pediatric Nutrition. Thank you very much, Dr. Habib, for joining us today. I think we will just defer questions till the end of the session for the sake of time. I'd like to introduce our next speaker, Dr. Noha Arafat, Professor of Pediatrics, Cairo University, from the Department of Pediatric Endocrinology. She'll talk to us about the cystic fibrosis disease from an endocrinal perspective. Samir.